Horizons is 10 years old, and so is our research group at NYU. I'm going to tell you about the first decade of our group at NYU, our current research projects, and then we're going to peer a little bit into the future. And I'm also excited to have two new members of our research laboratory, Sarah Menengah and Sam Podrebarac. Psychedelics as sacraments have been used for millennia. If you think of peyote in the Native American church, ayahuasca and Brazilian churches. Albert Hofmann accidentally discovered LSD in 1943, and that really started this very interesting period within psychiatry that essentially was buried at the end of it. When I was a psychiatric resident, I learned almost nothing about it. But what was really interesting is that LSD was studied extensively within psychiatry. There were over 1,000 studies. They were studied for addiction. Alcoholism was the most studied. Terminal cancer, anxiety, and existential distress was studied as well. It was a big, big part of psychiatry. And it went on for a while until Richard Nixon essentially put a stop to it in 1970 by declaring war on drugs, a war that the prosecution of it has ended up harming patients that I treat at Bellevue, predominantly minority individuals, suffered from this war against diminishing consciousness expansion. But after a 22-year hiatus, Rick Strausman at University of New Mexico brought it all back with IV DMT trials. And since then, groups at Johns Hopkins, Charlie Grob at UCLA, University of Arizona, our group at NYU, New Mexico, Michael Bogenschutz, who we now have recruited at NYU, and University of Alabama is also studying psychedelic research. This is all in the United States, of course. There's plenty of research going on in Switzerland and Great Britain. Our group started in 2006. Myself, Tony Bosis, and Jeff Gus started the group at Bellevue through some serendipitous meetings. Alex Belzer was also an original founding member of the group. And really what we have done over the last 10 years is a couple major things. The first major thing is we recently completed a randomized controlled trial using psilocybin to treat cancer-related psychological and existential distress. And we're very excited because that's going to be published very shortly, and I'm going to show you the results of that. We also did a qualitative trial of psilocybin that's going to be published as well. I recently completed a trial using IV ketamine. It was the first trial of ketamine to be given intravenously in an emergency room setting to treat patients that had severe depression and suicidality. These patients were admitted to inpatient psychiatric unit. And we also established a psychedelic psychotherapy training program. I'm a training director in addiction psychiatry, and I realized that training psychedelic therapists was so unique, we had to establish a program, which we did. We trained over 25 psychedelic therapists. And I'm going to mention the period into the future, how we're going to expand that training program. In 2006, we went from a psychedelic research group to forming an experimental therapeutic research laboratory. And our focus now is large. And I'm going to tell you about a soon-to-be established, first ever academically based psychedelic research center that will be housed at NYU and Bellevue Hospital. Our team has grown rapidly. We have over a dozen members. And what we are currently doing, in addition to finishing up the cancer study, we have additional time points for that trial. We are getting ready for phase 3 of cancer-related distress, which is very exciting because it potentially puts psilocybin on track to be rescheduled. We have an active trial led by Michael Bogenschutz, randomized controlled trial of psilocybin treatment for alcohol addiction. Samantha is going to talk about a neuroimaging component to that. And we are also, in conjunction with Johns Hopkins, engaged in a randomized controlled trial of psilocybin administration to religious professionals. So why dentistry? That's a sort of a bizarre thing. I'm not trained in dentistry at all, so it really is less fancy than it sounds. I've been working at Bellevue Hospital since 2000, and when we decided to do the cancer trial, it took 2 years. We had approval to do it, but we really didn't have a host place. And the dental school came out of nowhere to let us know about them. I didn't even know NYU had a dental school at the time, but turns out they're the only dental school in the US that, in addition to doing dental studies, also does medical studies. The cancer trial was a unique collaboration between the NYU School of Medicine and the College of Dentistry. We now have relocated our psychedelic research lab back at Bellevue Hospital, but it is really amazing to have worked with our dental colleagues. Our initial group, almost all women have been added, except Michael Bogenschutz, who's been a major recruit for us. Our team now is powered by women. We have space at Bellevue Hospital on the 22nd floor. We have about 12 offices, which is the administrative component of our new center. The room there is our psychedelic administration room, which is in the NYU Clinical Translational Science Institute. So we really now have the infrastructure to create this new psychedelic research center. So our cancer trial, this is the main thing I want to talk about. Cancer is really a disaster and a nightmare. About 40 to 50% of individuals in the US will be diagnosed with cancer at some point in their life, and the amount of anxiety and depression is very common. The amount of existential distress is common, and it's consequential because untreated, this decreases survivability, it increases suicidality, and we really don't have any great medications or psychotherapies to treat this type of distress, and we have no pharmacotherapies for existential distress. So we just completed a double-blind, placebo-controlled trial. We recruited 29 individuals, and this was done in conjunction with UCLA and Johns Hopkins. The findings here are very similar to the findings from Johns Hopkins, and were similar to what UCLA found in 2011. In terms of the design, we pre-treated people for 2 to 4 weeks. We went over the narrative of their life. We went over the narrative of cancer and how it was distressing them. We prepared them for the psychedelic sessions. They either got psilocybin 1 dose or niacin 1 dose. Following that, there was integrative psychotherapy. We drew from models of existentially oriented psychotherapy, psychodynamic psychotherapy, cognitive behavioral therapy. And then at 7 weeks afterwards, there was a crossover, and the group that got psilocybin first then got niacin, and same true of the placebo group. There was another 6 hours of post-integrative psychotherapy, and we followed up to about 6.5 months after that dosing. Although there was some medical and psychiatric adverse events, they were mild, they were self-limited, and there were no serious adverse events. And that goes along with the 2,000 or so times psilocybin has been administered in the US and Europe in controlled settings, which is the key. You can see here when individuals get psilocybin, there's an immediate reduction here in anxiety. And you can see the placebo group has a bit of a reduction, but it comes all the way back up. And you can see there's a big separation between these two groups. Same here, and we see it here for depression. The moment they get the psilocybin, there's a big drop in depression. It lasts this way for 7 weeks, and there's a big difference between the two groups. So there's an immediate and substantial and enduring effect. These are D or Cohen's D's. They measure the effect size, the relative difference between the two groups, and anything over 1 is a really, really large effect. So these were very powerful effects. And this is the 8-month snapshot, so you can see someone gets psilocybin, and look, 8 months later, they continue to have clinical benefit. After the crossover, it gets harder to attribute that to the psilocybin, but that's a big deal in psychiatry, that something would work so quickly to have anti-anxiety and antidepressant effects and would last as long as several months. In addition to that, psilocybin led to decreased cancer-related demoralization and hopelessness, these existential distress constructs. It improved spiritual well-being, and it increased quality of life. It did not impact death anxiety. The Hopkins group did find a decreased death anxiety effect. We did find, though, a decrease in death transcendence, in cognition or their thoughts or the adaptations to the finite nature of life. So it was hard to really understand what's going on here, but there is something related to improving their orientation to death. We also measured the mystical experience. The psilocybin group compared to placebo had much more significant mystical experiences. We did a mediation analysis, and the mediation analysis strongly suggested that it was the psilocybin-induced mystical experience that was one of the main drivers in therapeutic benefit in terms of reduced anxiety and depression 7 weeks later. So to sum, we established that we could do this safely. We established that it was feasible. We found that psilocybin is a rapidly acting anti-anxiety and antidepressant medication that lasts for 7 weeks, but as long as 8 months. There were decreased existential distress domains, improved quality of life, improved attitude towards death, and the mystical experience seemed to mediate the clinical outcome. What are the next steps? Our trials are going to be published in about a month and a half. They're going to be a major news story, and the articles, in addition to being a big deal by themselves, they're accompanied by 10 commentaries by the world's leading experts in psychiatry, addiction, palliative care. We have 2 former presidents of the American Psychiatric Association who've written commentaries. We have a former deputy drug czar under Ronald Reagan who's written commentaries. And when you look at the commentaries together, it's a really big deal because you can see that psychedelics have returned in psychiatry within the heart of medicine. This is not some fringe related thing. We are moving towards a phase 3 trial. It's going to be funded by the USONA Institute. The government will give approval, but will not yet fund these trials, so it's really venture philanthropists that allow this to happen. USONA is in discussion with the FDA to move potentially towards phase 3, and if that happens, it's a big deal. And again, look at these institutions that are probably going to be part of this. I mean, these are not small community colleges. These are enormous institutions within American medicine. And after the New Yorker article, it was amazing how many major academic institutions have contacted us. And what you will see next will be profound in terms of the number of major centers being involved in psychedelic research. We're very proud to have recruited Michael Bogenschutz from New Mexico. Michael is a real powerhouse. He is leading our randomized controlled trial for alcoholism. From the time of William James up until Carl Jung, up until Bill Wilson, we have known that spirituality is a big part of recovery. And I know that as an addiction psychiatrist. The most studied indication of psychedelics from the 50s to 60s was alcoholism. There were thousands of patients. The best data was there. So we have brought that back. Dr. Bogenschutz and I have designed a trial that's led by Michael. It's a randomized controlled trial. We're looking at the effects of psilocybin as a treatment for alcoholism. Sam is going to talk about the ancillary neuroimaging trial to that. We're doing a qualitative study. We've so far enrolled 30 participants. We need to enroll more. If anybody knows any alcoholics in New York City, please send them our way. We are physicians, healers. We are interested in decreasing the distress of patients that have psychiatric and addictive illness, but we also are branching out to look at some of these pro-social and other very interesting components of psychedelics. So we're doing a religious professional trial, which is in conjunction with Johns Hopkins. Tony Bosis internally is leading this trial. Psilocybin can occasion mystical experiences. This is a follow-up to the Good Friday experiment led by Walter Pankey. We recently just started this, and we're very excited to be doing it in conjunction with Johns Hopkins. It's funded by the Council for Spiritual Practice. Bob Jesse is here, and we really thank him for that. We are about to create a center at NYU for experimental therapeutics. It's going to be the first academically based such center to do research with psychedelics. And we're going to look at a whole host of compounds from psilocybin to LSD to DMT to iboga congeners, mescaline, MDMA, ketamine, cannabidiol, scopolamine. We have the physical space at Bellevue Hospital. We have a growing number of personnel. And with more money, we really will be able to do something pretty amazing. We have a donor who is close to providing $10 million to create the center. So this will be a big deal, and look for it soon. To end briefly, our end-of-life distress trial, the phase 2 trial we publish soon. We're going to go on to phase 3. But in addition, cancer distress is not just the disease of the individual, it's a family system illness. So we're now going to move on to using psilocybin treatment to help family members of patients who are suffering and to help the care providers like oncologists that suffer from burnout to help them in dealing with patients with cancer. We're going to be completing our alcohol trial. And Sam's going to mention the functional neuroimaging. We have also moved on to depression. The Carhart-Harris trial recently was very suggestive that psilocybin can help for depression. We have designed a trial now that will be led internally by an MD, PhD, Kelly O'Donnell, who is an NYU psychiatry resident. And our basic neuroscience, we're going to expand from religious professional to a whole host of things. Addiction is our main thing. It's my main thing. I'm an addiction psychiatrist. So we're going to go after all kinds of different targets, from alcoholism to tobacco, to stimulant addiction, to opiates, to behavioral addictions. We're developing a protocol to treat anorexia. We're going to go after OCD, generalized anxiety disorder, personality disorders, PTSD, criminal recidivism. We're going to be doing group psychotherapy. We're going to treat people with HIV/AIDS. Brian Anderson at UCSF has developed a protocol to use group therapy to treat patients that have AIDS-related distress. There's nothing specific to cancer in terms of having end-of-life distress. Almost any medical illness can do it. We're going to do couples therapy, family therapy, and we're going to expand our psychedelic psychotherapy training program, and we're going to do it by using the psychoanalytic model. To become a psychoanalyst, you have to undergo the experience. So we're going to add a psilocybin administration component to our training program so individuals can legally have the experience and understand the subjective state of the patient. In addition to that, we're going to bring back psychedelic psychoanalysis. Psychedelics used to be very much linked with psychoanalysis and psychodynamic treatment in the 50s to 60s, and we're developing a trial to administer psilocybin to psychoanalysts similar to the religious professional trial. We're going to see if we can use psilocybin to enhance spirituality, meditation, creativity, and conflict resolution. I wanted to acknowledge all of our funders, including at the level of the NIH and at NYU, and all of our private donors, and our group is large and growing. And on that note, I wanted to introduce our first speaker after me, and that is Sarah Menengah. Sarah is a real powerhouse. She's really amazing. She emailed me like a year back. At first I ignored it, and then she sicked her boss on me, and she wrote like, "This is the greatest person ever. You absolutely," in caps, have to take a look at her. We took a look at her, and she really is amazing. Sarah is ASU trained through and through, undergraduate, master's, and she got a behavioral neuroscience PhD there. She is an expert in the basic science of learning and neuroplasticity in rodent models, and in particular studying the effect of hormones and learning over the course of the lifespan of women. So Sarah, I'd like to welcome you to the stage.
I am a postdoctoral researcher, and I just joined the NYU Experimental Therapeutics Research Group in January of this year. So I'm brand new. So I don't have any data to present to you guys today, but I'm going to try to give you a little bit of insight into kind of where I envision myself moving in this role, and a couple of ideas that are circulating right now in our group. At a very basic level, learning and memory is essentially how you perceive, store, and retrieve information about your surrounding environment across your lifetime. A lot of people don't think a lot about learning and memory as being crucial to moment-to-moment existence and survival in the world, but it really is really important. It tells you a lot about your surroundings. We studied learning and memory across aging, so we looked at early and late life changes in memory. And one of the things that I'm really interested in is how a person develops kind of their sense of self across their lifetime relative to everything else in the world. So really it is through learning and memory that you learn who you are and how that relates to who everyone else is around you, and how you navigate your environment on a moment-to-moment basis. My graduate mentor, Heather, used to start all of her talks by saying that memory makes us who we are. She talked about it in terms of memory loss and things like dementia and Alzheimer's disease. If anyone in here has any relatives or friends that have developed Alzheimer's disease or any other type of dementia, then you know how really frightening and awful it is to lose your own personal memories. So that's kind of an extreme example, the outright loss of your memory. But there are a lot of other things that can go wrong with learning and memory that have slightly more subtle effects on personality. There are a number of researchers that have proposed essentially these neuroplasticity hypotheses of addiction, depression, and anxiety. If learning and memory go awry, and the way that you see yourself in the world and how you seek out reinforcement, if any of that goes wrong, these can create some very profound behavioral problems that lead to a lot of societal unhappiness and monetary costs and a lot of other things. So this is not new. These hypotheses have been around for a long time. But what is sort of new, or I guess renewed recently, is how they relate to psychedelics and health. We've got some really nice neuroimaging studies coming out showing that while people are under the influence of psychedelic drugs, they're experiencing widespread changes in network connectivity. We know from subjective reports that people feel things like unity, understanding, oneness with their surroundings. Basic visual hallucinations really seem to suggest a breakdown in very, very basic learning and memory processes. People are experiencing a breakdown in their own sense of how things should be. We also are seeing a lot of long-lasting changes in very complex behaviors like addiction, anxiety, and also changes in personality domains. And all of these things kind of come together to tell us what we know about what's going on in the brain, but the majority of the science that's been done so far in the recent past with psychedelics has been of the kind of flavor of applied science. So science can really either be kind of basic and exploratory, and you're really trying to understand how things are working, and then there's other types of science where you're really trying to take those questions and apply them to fixing some sort of a problem. So a number of the studies, all the clinical trials that we're doing for alcohol addiction and cancer-related anxiety and depression, these are all applied to some sort of problem. And so these are hugely crucial studies for getting actual FDA approval for these drugs to be used for specific purposes. But there's not a whole lot currently of basic science going on and really furthering our understanding of what these things are doing to the brain and how that kind of translates to changes in behavior. That's what I'm going to be trying to do in the future. And then I'm just going to talk very briefly to you guys about one basic science project that we're really interested in doing at NYU. We really want to study the safety and experiential effects of harmine. Harmine is a Beta-Carboline Alkaloid. It's found in this Banisteriopsis caapi vine. This is one of the ingredients used in traditional ayahuasca brews. A lot of people are familiar with it as the MAOI. This is a monoamine oxidase inhibitor. It allows the DMT, which is in another plant that's mixed into this, to become orally psychoactive. But what a lot of people don't know is that it also contributes a lot to the very unique individualized properties of different ayahuasca brews across tribes. In the last 5 or 6 years in the basic science world, there's been a really strange explosion of research on harmine. One of our collaborators in graduate school found some really interesting impacts on Alzheimer's disease relevant pathologies in cell cultures. So Alzheimer's disease related plaques and tangles seem to be ameliorated by harmine. I did a study as a follow-up to that as a model of aging in rodents, and we found that harmine enhanced spatial working memory. Some other groups have done some other domains of memories and found improvements there as well. And a whole number of studies have been done just in the last couple of years, and more are coming out currently, showing that harmine is neuroprotective in a number of different studies of different sorts of brain insults. Traumatic brain injury, hypoxia, ethanol-induced neurodegeneration, stress, and a number of other things have all been shown to be reactive to treatments with harmine. Dr. Bogenschutz, Michael, one of our another principal investigator with us at NYU, just published a study with a number of his collaborators looking at regular users of ayahuasca brews, and he was comparing them to other folks who attended church regularly but didn't use psychedelics. And they found that in these folks who were regularly using ayahuasca brews, they found lower rates of depression, confusion, different sorts of memory vulnerability, and they found that they were also higher in scores on agreeableness and openness. So all of this really fits nicely with the basic science research that's been coming out. So we want to try and start up a new trial looking at just very basically the effects of harmine in humans. We want to do some safety measures and things like that.
It's a real pleasure to introduce Samantha Podrebarac. Sam is a clinical research coordinator in our laboratory. Sam is currently a clinical psychology graduate student at the Spirituality Mind Body Institute at Columbia. She got her graduate degree in visual cognitive neuroscience.
My main role in the lab is involved in coordinating the phase 2 alcohol trial. And I'm also doing graduate work examining the role of spirituality in psychology. We're going to start and go through the ancillary imaging project that we are in the process of developing. We're recruiting 40 patients from the main trial, and we're looking to scan them on 2 tasks for 1 to 2 days before and after their dosing session. They'll receive a resting state task, and that scan is examining network connectivity in the brain. And the other scan is the functional scan. So we're looking at the brain activity or the bold signal when patients are presented with visual stimuli. So we're presenting them with alcohol cues, emotionally valenced cues, so positive and negative images, and neutral cues within the scanner. So there's a schematic here of one of the runs, just so you can get a feel for what the actual protocol looks like within the MRI. From the time that the scanner is turned on to off, patients are presented with sets of images intermixed with a baseline or a rest period. There's a number of, for instance, in this case, alcohol-related cues, and we're measuring their neural activation in response to viewing those cues and comparing it to neutral cues. We're making a distinction between the 2 groups, so the psilocybin-treated individuals and the diphenhydramine or Benadryl control-treated individuals across a number of comparisons, so examining their brain activity to alcohol cues, positive cues, and negative cues relative to neutral. So we're looking at whether the dosing session actually changes their neural response to these images. The next study that we're actually in the process of developing is examining the role of peak spiritual experiences in developing pro-social values or characteristics that relate directly to human relationships. So this is based on secondary outcome measures that have emerged from our group with the cancer data from Roland's group, showing that there's altruistic benefits to the psilocybin dosing session that's related to the mystical experience. So we're seeing positive effects socially, we're seeing enhanced quality of life. So there's something going on at the level of relationship value after a dosing session. So the question here is getting at whether psilocybin-facilitated mystical states can create persisting or lasting changes in attitudes and social behavior. So the meat of this is really getting at whether psilocybin can change a person's relationship with themselves, with others, and also with the environment. So we're looking to dose 40 healthy adults and follow them up for roughly 6 months and do a number of measurements throughout the process. So measure the intensity of the mystical experience, a number of pro-social traits, and we're also interested in examining racial bias. I am a researcher and an aspiring psychedelic therapist. So I'm really interested in examining the role of altered and transcendent states in terms of how they can inform us about the nature of consciousness and perception. So patients from a number of studies and the alcohol trial as well will report that the experience is more real than waking reality. So this raises the question of what actually constitutes reality and how does our conscious mind mediate and potentially even create what it is that we perceive to be real. The other line of interest for me is really examining whether spirituality has a role in the framework of a person's overall health, so in particular at end of life. But it's really looking at whether psychedelics can influence a persisting spiritual perspective and whether that bolsters resilience long term. So the final vein is examining alternate routes to altered states. I think there's a lot of importance and there's a lot of value in looking at altered states as facilitated through psychedelics, but there are a number of other routes that I think deserve acknowledgement and exploration from a research perspective. So things like fasting, meditative practices, breathwork, prayer can all bring us to altered states as well that can have therapeutic and behavioral potential. So I think it's worth looking at these altered states and particularly examining them in the context of enhancing the effects that we're seeing with psilocybin dosing sessions. So it isn't just a matter of having somebody enter an altered state and bring them back down. Rather, it's supporting the time in between dosing sessions with a practice or something that can enhance those behavioral changes long term. We're actually developing a meditation study that will follow the alcohol trial. So patients who are interested will be invited back and they'll be assigned with one of two styles of meditation. So one will be based in loving kindness and more of a self-compassion framework, and the other will be more of a mindfulness or a light vipassana style script that they'll learn and they'll be able to take home and hopefully implement daily. So we'll be looking across the following 6 to 12 months, still in development, to see whether that can sustain changes in their drinking behavior and depression rates and anxiety and a number of outcome measures.
To reduce expectancy bias, you do want to have a control that we call as active as opposed to something that's saline. So there are various active controls that have been tried. We tried niacin in the cancer trial. It doesn't blind that well. Its integrity is not great. The Hopkins trial, their 2006 trial in normal volunteers, they used methylphenidate. There was some relatively good blinding integrity. In the cancer trial, they've used low-dose psilocybin. So diphenhydramine is a way to obscure some of the effects of psilocybin. We're going to see if that works or not. You have to be careful because it has anti-muscarinic effects, and that's what got Bill Wilson sober at high doses. We don't think that that's going to do that, but we're trying to mimic some of the effects and obscure some of the effects of psilocybin for both the participants and the therapists. Diphenhydramines lasts a similar amount of time to psilocybin, so the idea is to try to obscure it as much as possible. With the phase 3 trial, if it happens, it could be done in 3-4 years. Psilocybin potentially could be rescheduled in 5 to 10 years. That's pretty optimistic. If that is the case, psilocybin, you will not be able to go to CVS, get it at the pharmacy, and take it home. What likely you'll have to do is it'll be restricted to psychedelic clinics where they're accredited and there's oversight and there's safety. The therapists are trained. It's really key to make sure that the patients are safe. I like doing this in a hospital. There's no safer place on the planet than Bellevue Hospital if you have an emergency. So I think from the perspective of people who are sick and needing to be treated, I think the hospital and clinic is the right model. Whether they could be used outside of that for other things is a different issue, but I think therapeutically they should be constrained and confined to the right place and people that are highly trained and where you can make sure to assure for safety. If you look at animal models of psychedelics, DOI has been studied. There actually are GABAergic effects. So there may be acute anti-anxiety effects that are GABAergic mediated. In terms of longer acting effects, psilocybin downregulates the serotonin 2A receptor. The 2A receptor and its density is involved in anxiety disorder. So theoretically, modulation of that sub-receptor may confer some of the lasting biological effects. Or it may really not be in the biological realm. It may be that these experiences are so profound and salient that they cause psychological, spiritual shifts that lead to improvements in anxiety. We really don't know. It's an interesting question.
I absolutely think that all of these things are not mutually exclusive. A lot of the times people kind of look at them from different perspectives. So like I might be interested in molecules and how they interact, and someone else might be interested in how personality shifts influence behavior. But we can absolutely be talking about the same thing. So in all likelihood, psilocybin is a very complex drug pharmacologically, and we're still learning more about what types of receptors it hits and how it hits them and how it interacts across different systems. So I think for something as complex as anxiety or depression or addiction, the likely kind of mechanism is several. I would hypothesize that we're hitting a number of different receptors, and through this very complex intervention, we're seeing very complex personality changes, behavior changes, and these are all adding up to one big new person, kind of.
Timothy Leary was the first person to think about it and try it. The Concord prison experiment was an attempt for that. He gave psilocybin to patients. He ended up faking his data, so we don't really know if it was helpful. You know, there's also the apocryphal story of Charles Manson using LSD. So clearly, psychedelics can enhance sociopathy, but I think in the right context, they could be enormously beneficial. There was a recent study that Peter Hendricks headed at Alabama, which was a population-based study in the southwestern United States that showed that psychedelics were associated with decreased return to jail. And Peter is trying to study using psilocybin to treat cocaine addicts who are in the criminal justice system. I think when you have a compound that can make you have empathic resonance for someone else and potentially can increase resonance, and the things that Roland mentioned, tolerance and openness, you potentially could have a model to change a personality dimension that we think is fixed. Catherine McLean studied when she was at Hopkins showing that psilocybin can increase the openness domain was a real landmark study because it showed that personality traits could actually be altered acutely by discreetly giving a drug. So I think that there's enormous potential. One of the things we want to do in terms of conflict resolution is using MDMA and psilocybin to potentially deal with sides that are warring and hateful towards each other and acting sociopathically. So I think there's a lot of potential there. You obviously have to be careful, and it may not be that you can cure sociopaths with psychedelics, but you may be able to moderate very bad behavior, and we need that in our society. Psychoanalysis is looking for a probe into the unconscious. Freud thought dreams were the royal road, but I really think psychedelics are an amazing tool to get there. Carl Jung thought so as well. Some people say that psychiatrists are modern-day shamans, if you will. Psychiatry is not really considered necessarily part of mainstream science. I think part of that is the brain is so complicated, but it's really the most elegant and amazing organ to study. In terms of shamanic culture, we look at shamanic culture in terms of how we do it. We're constrained by a research laboratory in a hospital, but indigenous cultures and shamans have enormous wisdom over millennia, and we want to tap into that to create a model that takes into account ritual and somebody that's guiding the experiences and containing them and keeping them safe. Whether one day we would bring shamans into the laboratory and study them is interesting to consider. We'll see.
Increased connectivity is not the best way to describe these things. The real things that we're seeing here are changes. They're alterations in what's connected. And something that I think gets kind of lost in translation sometimes is that physical connections in the brain don't necessarily equate mental associations or those sorts of things. Sometimes physical connections can actually equate an inhibition of a certain association. So one of the things that I'm really interested in is how just changing the way that things are connected kind of changes the way that associations are made. So it's not necessarily that things are more connected or less connected. It's that the associations that you make on a moment-to-moment basis based on what you perceive and what you've perceived before and how in your mind you're kind of relating those two things changes across time. And quite honestly, I think that a breakdown in neuroconnectivity can be quite useful for some of these behavioral problems. So like I was saying, kind of throughout your lifetime, you build up this like sense of yourself. So you're constantly learning more about yourself and your environment and how it's related. And sometimes I think certain relations can become sort of overlearned, and that can lead to things like addiction, seeking out rewarded behaviors that are kind of societally unacceptable. So I do actually think that there's an absolute potential for a sort of breakdown in learning, and that could correspond to more connections or less connections or different connections. But I do think that sort of a breakdown in learning and then a bit of relearning might be particularly helpful for some of these behavioral problems. And people actually, along the lines of what you were saying, they report all sorts of interesting things like birth-like experiences, ego death. And to me, as from a basic science neuro standpoint, this kind of sounds to me like the kind of structure of everything that you've learned throughout your life and how things should be, which absolutely shapes your perceptions on a moment-to-moment basis, has started to kind of break down. And then it's rebuilt over time after that. So this is all complete conjecture. Sam, do you have anything to add?
I'll add, sure, yeah. From the London group, they've actually found that there's, I think Roland touched on this, so there's less of a discrepancy between the default mode and the task positive network. So default mode is what's kind of happening in your brain, which areas are linked when you're at rest, and that's associated with self-referential processing, so focusing inward, focusing on, I would say, ego, versus the network that kicks in when you're actually focusing your attention externally. So task positive network, so different brain regions function in sync with each other when attention is focused externally. So in the studies from the UK group, there's less of a discrepancy between those two networks. So the difference, I mean, explain the ego dissolution thing and the things that underlie unity. There's less of a difference between self and other.